My name is Dr. Andrew Sun from the Stanford Department of Urology, and I'd like to thank the World Journal of Men's Health for allowing us to present our paper. The title of the paper is The Impact of Clostridium Histolyticum Collagenase on the Prevalence and Management of Peyronie's Disease in the United States. This disease is characterized by fibrous penile plaque formation in the tunica albuginea. This leads to penile deformities that may interfere with sexual function and cause discomfort. The true prevalence of Peyronie's disease is unknown, though estimates have ranged from 0.5% to 20% depending on the study setting. Further, there is little data on real-world utilization of Peyronie's disease therapies and the cost of treating Peyronie's disease. XIAFLEX was approved for treatment of Peyronie's disease in 2014. After approval, it joined verapamil and surgical approaches as the only treatment specifically recommended by American Urologic Association guidelines. There was significant interest in the use of XIAFLEX given the weak evidence for verapamil use and the invasive nature of surgical procedures. However, in these trials, 84% of patients who received XIAFLEX had an adverse event compared to 36% who received placebo. Further, all 6 serious events, including 3 corporal ruptures and 3 severe hematomas, occurred in the XIAFLEX group. Subsequent studies reported that 34% of urologists administering XIAFLEX have encountered a corporal rupture, and in one series, 4.9% of patients suffered the complication. However, to date, there have been no studies looking at population-level data to assess if corporal rupture rates in men with Peyronie's disease have increased after XIAFLEX availability. As there is a paucity of real-world data surrounding Peyronie's disease and treatments, we sought to characterize the prevalence, treatment, and cost of treating Peyronie's disease using a national insurance claims database. Further, there have been no large-scale studies evaluating the impact of XIAFLEX on practice. Our approach allowed us to compare management of Peyronie's disease before XIAFLEX was available to after and evaluate for changes. So, we used the Clinformatics database to generate a cohort of men over 40 years old that were insured between 2008 and 2016. This is a de-identified database that stores data from adjudicated and paid insurance claims and included 3.7 to 4.9 million men annually, representing a geographically and ethnically diverse population. Using this data, we were able to calculate prevalence, treatment rates, incidence of corporal rupture, and cost of treating Peyronie's disease for each year. We were then able to compare the years before and after XIAFLEX, namely 2004 to 2013 and 2014 to 2016. The annual prevalence of men with Peyronie's disease rose from 0.09% in 2004 to 0.29% by 2013. We did not see any change in the prevalence of Peyronie's disease after XIAFLEX became available in 2014. The age groups with the highest prevalence were men 50 to 59 years old, up to 0.38%, and 60 to 69 years old, up to 0.48%. We should note that our prevalence estimate is lower than previously published estimates, though it is close to the 0.5% prevalence of a similar population-based study. We theorize that our lower prevalence may be due to a younger cohort and reflects that Peyronie's disease may be an underdiagnosed condition in population-based samples. In general, our findings are congruent with the accepted understanding that Peyronie's disease prevalence increases with age. However, the prevalence in patients over 70 years old declines substantially. Whether this represents underdiagnosis or is directed by patient and provider desires requires further study. The annual percentage of men with Peyronie's disease who received treatment ranged between 2.2% and 2.36% before XIAFLEX was available. A cumulative 2.52% of men were treated during this era. The rate of treatment increased to 3.36% when XIAFLEX became available in 2014, and further increased to 4.04% by 2016. A cumulative 3.75% of men were treated during this era. This increase was found to be statistically significant. Corresponding to the increase in treatment rate, cumulative rates of penile injection increased from 1.34% before XIAFLEX was available to 2.61% after. This increase was also statistically significant. Average rates of penile plication, penile grafting, and penile prosthesis appear to decrease when comparing the same periods. From this data, it appears that a higher proportion of men with Peyronie's disease received treatment after Xiaflex became available, and this increase is due to more utilization of penile injections. Median annual inflation-adjusted cost of Peyronie's disease treatment rose from $5,800 per man in 2008 to more than $10,000 per man in 2016. While the costs were overall stable before Xiaflex was available, ranged between $2,900 and $5,800, they sharply increased in 2014. From 2014 to 2016, the median cost ranged between $8,200 and more than $10,000. The increase in cost between eras was statistically significant. Overall, we found that Xiaflex availability was associated with a large increase in the cost of treating Peyronie's disease. Unfortunately, we lack the required clinical data to comment on if this increase in cost is justified by improved patient outcomes. Future studies should assess if Xiaflex is a cost-effective way to manage Peyronie's disease. A total of 25 corporal ruptures occurred in men with Peyronie's disease during the study period. When comparing the years before and after Xiaflex entered the market, there was no significant change, with both eras having a 0.024% rate. From these numbers, it appears that the overall risk of corporal rupture is quite low in men with Peyronie's disease, and use of Xiaflex has not significantly increased this risk on a population level. However, up to 34% of urologists using Xiaflex have reported experience with a corporal rupture. It is possible that such events are not reliably captured using administrative claims data, as nonspecific codes, such as those for penile hematoma, may also have been used. We acknowledge several limitations. The data used for our study does not include clinical outcomes of patients, so the efficacy of Xiaflex in practice could not be assessed. Similarly, clinical data such as severity of penile deformity or curvature is not included. The number of corporal ruptures identified was small, limiting our ability to make definitive conclusions about that topic. Our study design cannot control for variations in diagnosis and coding behaviors between individual physicians. Though diverse, our study population is an insured population, and our findings may not be representative of uninsured patients, who may represent an undertreated group in general. In conclusion, this study investigates the efficacy of Xiaflex availability on Peyronie's disease prevalence and treatment. While no change in Peyronie's disease prevalence occurred after Xiaflex entered the market, a significant increase in the proportion of men with Peyronie's disease who received treatment, specifically with penile plaque injections, was found. In contrast, less men underwent surgical repair for Peyronie's disease. At the same time, there was a significant increase in the annual cost of Peyronie's disease treatment. Investigation into rates of corporal rupture found no change in men with Peyronie's disease as a whole after Xiaflex entered the market. Future studies should assess if Xiaflex is a cost-effective way to manage Peyronie's disease.